Welcome back, Richard. It's good to see you this morning.
Good to see you too. Another hurricane coming our way.
Yes.
Getting ready for that next week. So
Well, this time of year, there's almost always one coming our way. It's just a matter of whether it makes it or not. So
yeah. But what month is this? September. So this is early in the hurricane season.
Yes, we still have a little bit to go. So
Right. Yeah.
Well,
So, but otherwise, all is good. The weather's cooling off a little bit, a little less humid, a little bit cooler in the low 90s and high 80s.
yeah.
So, but you're doing well.
Doing all right. Doing all right. And today we're going to talk about kind of an extension from last week, but thinking about are you doing all right? It's this idea that we talked about last week is about symptoms and just the difference between symptoms and disorders, and how so often we are working to treat symptoms, but we're not really looking at that underlying cause of the symptoms. And because of that, we tend to get our treatment wrong, and we tend to have some difficulty helping people overcome some of those symptoms. And so today we're going to extend that conversation, because just thinking about some other ways to look at treatment, sort of the traditional cookie cutter treatment versus what we're going to call personalized care, personalized treatment.
Right. Yeah. There's a growing body of literature now that we know that mental illness in general, rates of mental illness in general are increasing, especially depression and anxiety. Most of us are aware that rates are increasing among women and minorities and teenagers. And there's another issue of whether what we do as mental health professionals is really effective in meeting that need. And so are we doing the best work that we can, given the increased rates of the increasing rates of mental illness? So not only do we question ourselves, or how are we doing as mental health professionals, but also are we really meeting the needs of people who seem to be struggling more?
Yeah.
And so in the last week we talked about this notion that just because you have symptoms doesn't mean you have a mental illness, doesn't mean you have a disorder, that there's a big difference between symptoms and a disorder. We want to talk a little bit more about that today. And there are actually two separate articles that we're going to be talking about today. And each of these offers a solution to the challenges that we face. And when I say we, I mean we as professionals, but also challenges that our clients or our patients face in getting the kind of care that they really need, effective care that they need.
Absolutely. As we've talked about many times on the podcast, our perspective is, one of the most important things that you can do is ensure that you have the right diagnosis. And, so often people come in and they will claim to already have a diagnosis, or they will talk about a diagnosis as though a diagnosis has been evaluated and made. And really what's happened is they've looked at a cluster of symptoms, or they've maybe gone to a professional who hasn't taken some additional steps to ensure and really, identify the appropriate diagnosis. And then by and large, what happens is that whatever treatment was prescribed, or whatever treatment one would predict should work or should be effective for that person, it doesn't work. It falls short. Sometimes the treatment will seem to be effective at the beginning, but then it'll lose effectiveness despite integrity with completing the treatment, or the treatment just never works. People get worse, or they experience other symptoms. And so we had the good fortune of working with a psychiatrist earlier in our career, where that was the emphasis, right? We have, from the beginning of our training, been sort of informed and encouraged to really consider the significant importance of finding that diagnosis, identifying that diagnosis, and then applying a correct or appropriate intervention, that that then tends to be adequate. It tends to help and be beneficial for the patient.
Right. Yeah, there are really two problems here, and I want to try to keep this simple, but you can get the wrong diagnosis. It's easy to criticize psychologists or psychiatrists or any professional. It's very easy to criticize, but these are complex problems, and there's not only the question of, do I have the right diagnosis, which is very important. There's a big difference between depression. Is it depression or is it ADHD? Is it bipolar depression or is it reactive depression? So there's that issue of whether I have the right diagnosis. But there's a second, more subtle difference, and that is, am I talking to a person who's simply having a rough time right now? They're a little bit sad. Or am I talking to a person who truly has, when I say true depression or severe depression, because we also have to get that right, that it may be depression, but it could be just a mild case of the blues, or, a temporary setback, a loss, a job loss, a loss of a loved one. And so you have a response to an event. And that's one kind of what we call depression. And there's another kind of severe or true depression that is the symptoms are much more severe. So it's not just getting the right diagnosis, but it's also, am I dealing with the true version, or am I dealing with the light version of a disorder? And those are important diagnostic questions that we're obligated to answer.
Yeah, absolutely. And we talk about this a lot, say with ADHD, for example, because, as I've said before on the podcast, you can create a situation, you can create an environment within which most anyone would look as though they have ADHD, right? You can affect the temperature of the room. You can affect how much access they have to food and water. You can, influence what is being discussed or what is being expected of the person. And you can create a scenario where people have a hard time sitting still. They have a hard time focusing and all of that. That's not ADHD. It just means that you're creating that situation. And so, as you said, you have sort of some symptoms and characteristics that could be an appropriate response to what's happening in the person's life. If the person is very unhappy with their work, unhappy in their relationship, unhappy with so many things that's happening in their life, yeah, they may have symptoms of anxiety or depression or distress in many ways, but it doesn't necessarily mean the same thing as true depression, major depressive disorder, because, you're talking about something that is a result of what's happening in their life versus something that's sort of endogenous and something that's happening from inside them, that biological based depressive symptoms.
Right. And how often do we hear, well, I don't want to take drugs, or I've taken drugs and they don't work, or I've been to a therapist and it didn't do any good, or it didn't help. And we hear that very often. And we believe that the reason people don't get effective treatment is that there's more to it than dealing with the symptoms. There isn't a lot of evidence that medication alone, or even standard psychotherapies, like what we call evidence-based therapies, make therapy more effective over time. I mean, you assume that a person has that, you have some symptoms, and so you either prescribe a medication, or you use cognitive behavioral therapy or dialectical. So you sort of throw a treatment out there. If it works, great, but it's not science. I mean, it's more like, you have these symptoms, I'm going to try this medication. You have these symptoms, I'm going to try this evidence-based therapy. That has not been very successful. We already know that using those standard sort of cookie cutter approaches are not effective over time.
Right. Absolutely.
Okay.
And so
we're looking for an alternative. You and I have been looking for, okay, so if that approach doesn't work, What can we do? And I think this article offers a possible solution.
Right. And it talks about what we're referring to again as personalized treatment. And
Exactly.
what we're talking about with personalized treatment is a treatment that is centered more specifically to the individual patient or client. It looks at the entire context within which the person presents and seeks to sort of match the needs of the patient, the circumstances of the patient with whatever intervention is going to be implemented. And so we see that very often as an important considerations, because when we're looking at someone who has sort of this complex presentation, teenagers are a good example of this, because parents often think, well, my teenager is experiencing these symptoms, they're angry all the time, and they lock themselves in their room, and so I want them to get therapy. Well, if a teenager comes into a therapist's office and the therapist says, well, we're just going to do this CBT and we're just going to follow this routine and do this, you're not going to be very successful, because you're not really working with the teenager. You're just following the parent's desires and what the parent wants. That CBT approach may be evidence-based and show that it should be highly effective and should be really, beneficial for the kid. But if you're not looking at what's going on with the kid specifically, with that particular teenager, it's not going to be very effective, because you're not really going to get their buy-in and they're not going to appreciate it in any way.
That's right. The value is not in the therapy or in the medication. Those things are part of a larger intervention program.
Right.
Medication may be necessary, but it's just one part of a personalized approach to treatment.
Yeah, absolutely. So when we consider all of the different life circumstances that a person may be experiencing, then we can tailor a specific intervention and sort of approach to treatment that the likelihood of benefiting the patient significantly increases. And so you mentioned there's two articles. In the second article, the author is addressing the issue more specifically of depression.
Right.
And when it comes to depression, it is a significant issue. I mean, it is one of the leading causes of distress all over the world. Professor Eileen Anderson at Case Western Reserve talks about depression as being the leading mental health challenge, not only in the United States, but it's the number one global burden in health and concern about a person's overall well-being, more so than anything else, heart disease or any other illnesses. And so depression is a major issue that should be discussed.
Right. Yeah, I didn't realize that we know that rates are increasing in the United States, and it's partly the pandemic, but these rates began increasing 15 or 20 years ago. So it's not just the pandemic, and it's not politics, and they began increasing years ago. So we know that rates are increasing. I didn't realize they were increasing worldwide. Right. So, but worldwide, about 5% of people suffer from some type of depression. But the US rates are much higher than that. The US rates are about 17, 18%, which is, and that's a 70% increase in just the past 8 years. So we're talking about almost by more than a factor of 3. There's 3 times as much in the United States as anywhere else in the world. In fact, the only country in the world with higher rates of depression than the United States is the Ukraine. Right. And we all know the Ukrainians are going through right now. So we know the effect that war has on these kinds of things. So we're looking in our country, worldwide it's 5%. In our country, it's 18% for adults and 20% for teenagers. Right. So this is a significant and troublesome increase. Now, you can say that, well, we're better at identifying it than they are in other countries. We have more resources, we have more clinics, we have more specialists, but that's not a sufficient explanation for the increase. So the first question is, why is the US so depressed? Why are we so depressed? The simple answer is we're not sure.
Right.
There are some factors like poverty and physical health, where rates of physical health are worse, depression tends to be increasing. But we really don't know why the US is so much more depressed than everybody else. The other more important question for us as providers is, why do some individuals slide into depression and others don't?
Right.
What, if the rates are so high, if the rates are approaching 20%, why isn't everybody feeling this? And again, we're not sure.
Right.
But probably the best explanation is something that we used to call the stress diathesis model, which is that certain individuals are simply more susceptible, more prone to depression, and life circumstances present them with significant challenges. So there's some interaction between the stress that you're feeling in your life and your vulnerability to depression or anxiety or any other of these conditions.
Right. When we're talking about susceptibility, many times what we're talking about is your biology. We're talking about genetics, we're talking about, chemistry, we're talking about a lot of other things. So it's not surprising that those groups of people who are experiencing significant changes biologically, like teenagers, that they, when you put them under significant amounts of stress, which we do, that the rates and presentation of depression or anything else significantly increases. So they are going through these biological changes, which changes their brain chemistry, which changes the way that everything in their body is working. And then you put them under this stress, and so it's going to express itself more readily. So
that's right.
Diathesis stress model helps us to understand that when you have this biologic or genetic predisposition to something, when that stage is set, the addition of some stressor, especially a significant stressor of some sort, can trigger that expression, and then you see it more readily.
That's right. And if you have a family history of depression, remember, we not only inherit our parents' hair color and shoe size, we also inherit their brain chemistry. And so if you have a family history of depression, you're at higher risk for depression. If you have a family history of anxiety, if there's no family history, then there's a smaller likelihood that you're going to be vulnerable. A smaller likelihood doesn't mean it's not going to happen. It means a smaller likelihood. Given all of that, but the other thing that we know is that behavioral choices, how we respond emotionally, and our daily habits, sleep, eating, drug use, alcohol use, all of these things contribute to set the stage for a person to slide into depression. So it's heritability, it's vulnerability, it's increased stress, but it's also a person's behavioral choices, lifestyle, emotional responses that also contribute. And this is where we return to the idea of personalization, because if as professionals, if we're not accounting for all of these variables, we're doing a disservice to the patient, because different people have different life experiences. So I can't just impose cognitive behavioral therapy on every patient, because each patient is different. Some need it, but some don't. And that's a clinical decision that we have to make.
Absolutely. And so we all know that, when a person has authentic, true sort of endogenous biological depression, that it's more than just sort of feeling melancholy or having periodic episodes of sadness. And we also know that when a person has that true biological endogenous depression, that medication alone, many times psychotherapy alone, isn't sufficient. The person needs more. And so when you're thinking about this idea of individualized treatment and personalized treatment, as I mentioned earlier, we're talking about treating the entire person. We're talking about not just saying, hey, let's treat these symptoms. I think one of the most difficult things, or one the biggest limitations to things like cognitive behavioral therapy or some of the other different therapeutic approaches is that the goal is to avoid those symptoms. For example,
Right.
you know, when you're feeling distressed about something, when you're feeling anxious about something, you know, we work really hard to stop thinking about that. We want to avoid whatever it is that's
Right.
making us anxious. Well, sometimes the best approach is to attack that whatever it is that's making you anxious. If a test that you have to take tomorrow is making you super anxious, the best way to address that is to study for the test and then go take the test.
Right.
Because guess what? After you finish the test, that anxiety is gone. So,
Right.
so if we only look at, okay, the person is experiencing anxiety, this is a treatment for anxiety, let's give them Xanax or let's give them this treatment. But you fail to look at, no, this is very situational, this is very specific to this situation. So all we need to do is address this part of the problem. Well, the effectiveness isn't going to be there. The person isn't going to find the relief that they need. And so we need to be very personalized when it comes to addressing all of these symptoms for the person.
That's right. Right. But yeah, so when we talk about personalized care, we're talking about providing a range of therapies, you know, not
Right.
just medication, not just a particular type of psychotherapy, but we're also talking about lifestyle changes.
It's huge.
You know, we have to address those other issues. We also have to address underlying conditions. You know, is the person physically healthy, or do they have some chronic illness? And we need to consider that. And we use medications, but we use medications when they're necessary.
Right.
So every person who has clinical depression needs individualized help and tailored solutions. And there's a guy by the name of Richard O'Connor who wrote a book called Undoing Depression, where he suffered from depression because of some life experiences that he had. So he's a therapist, but he's also been dealing with depression himself. And he said there are dozens of additional steps that people need to take if you truly have depression. And he mirrors what you and I always tell our patients, and that is that you have to do more than just the typical therapies that we throw at people, whether it's psychotherapy or medication therapy. You have to improve their diet.
Right.
Okay. You have to talk about diet and nutrition, more physical activity, more social contacts. You may need individual therapy, improving your sleep, meditation, and medication. The thing about medication is that medications are usually more effective with severe depression, but they're not as effective with mild depression.
Right.
So if you're just struggling with mild depression, it might be good that you don't put too much stock in how effective medication will be, because medications aren't as effective with mild depression as they are with severe depression. So it's not the fault of medication. It's just that medication works differently with different people.
Yeah.
So the advice that we'd like to end up with, that we'd like to end with, is that, first of all, people with severe depression cannot climb out of the depression on their own.
And Richard, I think that that's so important because, you know, the other morning we were having a conversation about some patients that we're working with, and there are those people who are experiencing depression or anxiety or a number of different things. And their expression or their experience of it is so entrenched in their biology. It's not just, you know, you look at them and you're like, man, they have, you know, they have financial resources, they have social and supportive resources, they have, you know, they don't have any of these other demands or things. And so, you know, looking at it, at least on the surface level, for the most part, they don't have any of those environmental things that could be contributing to their symptoms, but yet they experience it in such a debilitating manner. And when you see that, you can tell that there's not a way that this person is going to climb out of this on their own. They have been going through it for so long, and it is so has such a broad effect on their life and their lifestyle and their everything about them, that there's nothing that they can do about it by themselves. They need assistance, need help.
That's right. If you're struggling with some mild sadness, some mild depression, you might be able to do some deep breathing or some meditation, maybe a little medication, and it'll bring you out of that. But the more severe the disorder is, the more severe it presents itself, the more likely it is that you're going to need this personalized, very personalized and comprehensive intervention approach. Okay. That's number one. It's not going to get better on its own. It's deeply seated in the person's biology. Number two, depression is not one and done. Depression tends to recur over the lifetime. You might have it as a child, you experience it again as a teenager, you get it again in your 30s, and it tends to recur over time. And you have to be aware that you're not just going to cure it and never have to experience it again. Chances are you are going to experience it again. And one of the authors likens the treatment of depression to something like a treatment for drug or alcohol abuse. And that is, as with other forms of treatment, it takes a very deliberate effort. Right. You have to work at this. It requires a lot of work on the part of the professional, because they have to personalize care and consider all the facets that a person's bringing. And it also requires effort on the part of the patient. You have to work at this. It's like getting over drug or alcohol abuse or physical therapy. Right. You have to work hard to make yourself better. And so it requires a deliberate effort. That's why it's different with teenagers, because while parents might be highly motivated to have their child receive therapy, if the child's not highly motivated and the child isn't taking a deliberate approach, if the teenager isn't using a deliberate approach, nothing we do is going to change anything.
Right. And maybe more specifically, even medication isn't even going to help in those circumstances. No. If the person doesn't want to, it isn't committed to and making that deliberate effort that you're talking about, medication is far less effective. Psychotherapy is far less effective. It requires an intentional approach to making changes in your life. And that's why that personalized approach is so important, because we're not just saying, here's a blanket, a treatment that works for most people and it should be effective for you. Right. Because as soon as it's not as effective as expected, the patient loses motivation, they lose interest, they lose drive. You have to make it personalized for the patient so that they can see some of that benefit. It may be difficult. It's never easy to tell a person, well, you got to change this part of your lifestyle. You have to start exercising more. You have to stop eating those kinds of foods because it's not helping you. That's not easy, but it will start moving in a positive direction for the person.
That's right. If you suddenly get diabetes, or you have a heart attack, you have open heart surgery, you're going to be given a whole list of things you have to do. You have to change your diet, you have to exercise, you have to sleep differently, you have to get rid of your stressors. It's no different with these mental illnesses. Absolutely. It takes a deliberate, comprehensive effort.
Absolutely. So, all right. Well, that is it for this week. We will be back to certainly talk about more of these kinds of issues over time.
I was going to do a spoiler alert for next week, but
are you?
Start of school. And many parents say, my child's not motivated.
Right.
We're going to talk about motivation next week.
All right.
Okay.
Back for that. All right. So until then, stay happy, stay healthy, and forget to be afraid.